All right, guys, I think we're going to go ahead and get started. Hopefully everybody can see my slides. My name is Erin Benekos. I'm a nurse practitioner at CHOC for the Adolescent to Adult Bridge program. We call it the A to B program. And I'm also joined by Courtney Malave, who is our licensed clinical social worker. And she's our A to B clinic social worker. So we're really excited to be here today to talk about something that we're very passionate about, and that is pediatric to adult care transition. Specifically today, it's going to be related to epilepsy. So we are going to discuss our program and how we have joined forces with CHOC's Epilepsy Center, and we'll be happy to answer questions at the end. Let's see. Sorry, guys, it's not advancing. Give me one sec. Rennie, are you able to pull up the slides? Because mine is frozen.
Yep, give me 1 second and I'll pull up the slide deck.
All right, perfect. Okay. So as mentioned, we're talking about transition today, and just so you know, we have many different transitions in life, and so even as children with epilepsy get older, as with all of us, managing our own care is critical to independence. But even more so in going through this transition from pediatric adult care, having this smooth transition is really, really important for anybody that has a chronic condition. And that is because if there is not a plan that's in place, there can be disruptions in care, and our patients can end up getting some of their care out of the emergency departments, running out of medications, or sometimes even having an inpatient hospitalization. So we want to avoid that. Next slide, please. So we always like to show this slide of any time that we're presenting to really focus on what is transition. And we like to use Scott Transition's definition because it highlights that this is a process rather than an event. So transition is not interchangeable with transfer. Transition is this process, and it takes many years. So at CHOC, we are starting this program at the age of 12. So this is the time that we're starting to introduce to our families, what is transition, at what points will they be graduating from CHOC and leaving to go to another center. This is a time to really promote autonomy if that is appropriate for the patient, and then also increasing knowledge, skills, and abilities. Again, even though we use a core curriculum that we'll talk about today, it's important to know that we can also tailor it to each patient because every single patient's journey is going to be unique. We have patients that are going to be completely independent. We have some that are kind of going to be in between. So they're going to have some sort of independency, but still might need the assistance of a parent or a caregiver. And then we have some other patients that will rely completely on their parents or caregivers for their medical care and for other care, even activities of daily living. So through the transition process and through these many years, we also move through the 6 core elements of transition, which we'll talk about as well. And then transfer, like I said, is that discrete event. It is the warm handoff. It is leaving from one healthcare system to another. Next slide. So I like to use this slide. My background is actually in hematology oncology, and I've done a lot of work with our sickle cell population. And this was something that was at a presentation or at a lecture that I saw many, many years ago, and I loved it and I've kept it. And I've with Dr. Cantor, she's the one that has used this slide. So to really think of transition maybe as a metamorphosis. So this is a time of evolution. This is progressing from one stage to another. And so I tend to like to include this slide to highlight it, to think of this just to remind everybody that it is a process. Next slide. So when we think of transition by default or design, I really like to highlight the difference between the two. So default, thinking of aging out, reaching a certain age, 18, 19, 20, 21, where all of a sudden you can't be seen at a practice or a clinic or a hospital anymore. It is unplanned, there's no communication, and the patients and families are surprised that it's happening. They weren't told it's going to happen. So this is what we want to avoid. And sadly, this tends to happen. And this is what we're trying to move away from. Whereas design is systematic. It is planned, it is purposeful. It is what we are doing with our transition program, and starting early. So that way interventions, we can start our interventions early. It is preventative. And then we can also study our long-term outcomes. So we can see from, if we're starting at an early age and building on those knowledge, skills, and abilities, to how prepared are our youth, our adolescents, when it is time for transfer. Next slide. So what happens when our patients grow up? This was a study that was published in 2018, and I think it was really important for us to include today. It showed that a third of young adults who had active epilepsy prior to the age of 18 actually even had these discussions of transition. So meaning that many of our patients did not have that discussion with their provider that transition was going to have to occur at some point. So less than one half, so less than 50% of patients with epilepsy after that transition has occurred was even having follow-up care with an epilepsy provider. So half of our patients were not landing in adult care. So as I mentioned in one of the first two slides, is that this is what can happen if there is not a process in place. Our patients can end up going off their medications, ending up in the ERs, and having really bad outcomes. Next slide. And this is because of many barriers. So I've listed many barriers here, and it's from, not having the knowledge, for our patients and families not having the knowledge, the providers. So we are, just as fault. Many of the pediatric providers are fearful of letting their patients go. And especially in other specialties too, they say, you know what, I'm just gonna care for my patients as long as I possibly can, until I know they're ready, or I know that the receiving end, that there's somebody on the other side that's going to take care of my patient as well as I have. So it's on the provider side. There's breaks in the system, there's insurance barriers. So there's many things here that can cause that disruption in care and make it very, very difficult for our patients to have that smooth transition. But thankfully, we are working through every single one of these barriers. Next slide. There is a difference between pediatric and adult care. I'm sure many of you guys know that too. The pediatric side, you come into CHOC hospital, you see warm colors, you have Choco Bear, a lot of everything's very nurturing. We have patient family centered care. We have child services, but it's very paternalistic too. So there's a focus of directing a lot of our questions to the family or the parent, as opposed to the patient. Where adult care, that's different, right? So there's a shift, and a lot of our questions are now directed towards the patient, and we're expected for the patient to be able to actually answer those questions, talk about their medical care. Insurance is different too. So this is more of an employment-based insurance. We still have Medicare as well, and it's more autonomous. But it can be fragmented. So we have found that some of our patients, they could be receiving care at multiple organizations or multiple health systems. And then there's fewer providers, which could actually be a positive too. As many of you might know in pediatric care, if our patients are constipated, they go to GI. If they have any specific diagnosis, we're making sure that the specialist actually will cover that patient and care for that patient. But on the adult side, primary care is really the quarterback. And they start taking over a lot of this care that was previously done by a specialist. Next slide. So I wanted to note this just so everybody knows that transition doesn't have to, even though we like for it to start early, if the diagnosis does not happen until the teenage years, transition is still going to occur, and it should still be discussed as early as possible. So we have 3 different possibilities here, and I'm sure there's other ones as well. So we have early childhood epilepsy that can persist into adulthood. So an example of that is symptomatic, partial and symptomatic generalized. We have early childhood remission with a persistence of other associated comorbidities. So for some of our patients, they may be seizure free, they get weaned off their AEDs, in which they don't follow their care, their neurology care or epilepsy care into adulthood. Their care end up going to their primary care, but they still might be seeing a specialist for other reasons. And then we have a possibility of developing epilepsy in adolescence and persisting into adulthood, and that's JME. So regardless here, we want to be sure that we're discussing transition with all of our patients at many different points of time. Next slide. And as I mentioned earlier, every patient is unique. So we have some of our patients that are followed just by neurology or just by epilepsy. And we have other patients that are followed by 2, 5, 15 specialists. And so no matter what, everybody needs to be involved in that care. And the center of that is our patients and healthcare transition. Next slide, Rennie. You can go to the next one. So we've joined, like I mentioned, our Adolescent to Adult Bridge program has joined forces with CHOC's Epilepsy Center, Comprehensive Epilepsy Center. So we want to be able to show you a little bit of what that looks like. This is our small but mighty team, and we are growing. So I introduced myself as well as Courtney. We are also joined by Rennie Partain, who's actually thankfully advancing my slides for me. She is a licensed clinical social worker and our program facilitator. So she's really overseeing the program as we will be scaling it out CHOC-wide. Dr. Wendy Gray is a psychologist and is our research lead. And then we also have a quality improvement specialist, Paris, too. And Angelique, our transition medical assistant. So she's really involved in the clinic. And we are under the direction of Dr. Michael Weiss, who is the Vice President of Population Health. And just so you know, too, you can go to the next slide, Rennie. This is a strategic initiative. So this is something that CHOC from the very top has decided is a top priority for the institution. So we not only, I showed you the small group on the previous slide, but we also have a very large steering committee where we have representations from lots of different divisions, as well as patient and family involvement. So we have a parent of a patient that has epilepsy actually on our steering committee. So it's been really great. We are system-wide. So like I said, we're spanning from primary to specialty care. So this is really involving all of CHOC patients, regardless of diagnosis. But we started this first year with epilepsy, IBD, type 1 diabetes, and our childhood cancer survivors. And then we have our A to B clinic that I'll talk about in a little bit. We follow GOT Transition 6 core elements, which I'll show on the next slide. And just to give you guys an idea of volume, we have about 25,000 transition age patients. So that's 12 years and up that are seen at CHOC annually, and about 1,000 of them are actually leaving, we believe are leaving CHOC every year. So that just goes to show how important transition is really to everybody, because we are having lots of patients connected to adult providers every single year. Next slide. So these are the 6 core elements, which are really the pillars of our program too. And so you can see it starts from policy all the way to transition completion. So beginning with a policy, this is really just introducing what transition is. just starting that discussion with our patients and families and the importance of it, and then moving through the spectrum here. So tracking and monitoring readiness, providing readiness assessment tools, and then that way we can track that year after year after year to ensure that our patients are gaining those skills, the knowledge, the abilities to really master those elements by the time they get to 18, 19, 20, 21, where that's when they're expected to be connected to adult care providers. And then transfer of care, so that I mentioned earlier, that is the warm handoff. And then transfer completion. So even following up 3, 6, 12 months, 2 years later to ensure that our patients are actually doing well. So in our clinic, that's what we're going to be doing. Next slide. So the process can vary. So I mentioned patients earlier that may have been in remission with their seizures, came off their AEDs, and so they might just go directly to primary care, so family practice, internal med. And then we have our patients that are seen by our neurologist or epilepsy centers, pretty much under well control, may not necessarily need a transition visit with our team because a lot of their transition components are being addressed in their normal specialty clinics. So they'll just go directly to their adult providers. And then we have some patients too that are really more of the complex patients that see multiple providers, where a lot of their transition needs happen to be just really exceed what can be accomplished in their normal visits. And so that's when they can get referred to us. And then lastly, they'll get connected to a medical home. So they're adult providers. Next slide. So now that it's time to focus on our clinic, which we're really excited about. Next slide. So, and you could advance, Rennie, because it'll pull up kind of for our epilepsy patients. So for our population, we're really focusing on the advanced and complex pathways. The standard pathway is for our primary care patients that don't have a chronic condition, but advanced, it was kind of what I alluded to on the previous slide, where there's a moderate need, but their transition services are in the primary and specialty clinics. But then that complex pathway, so multiple providers, or they have any physical, emotional, special needs, a lot of community resources, those are referrals to our EADDL clinic. So if you are a CHOC patient and your provider happens to talk to you about the clinic and say, you know, I really think that you would benefit from the EADDL clinic, this is why. So it's just a separate visit, which currently is 100% telehealth. So it's just over Zoom. Where it's adolescent centered. We do a complete history and physical, lots of disease education. We go over the transition readiness assessment and provide care coordination and really make those recommendations back to the referring team to assist with that smooth transition that's uninterrupted. Next slide. So a couple different scenarios. We might have a 19-year-old female with complex partial epilepsy. She's also followed by pulmonary and sleep for obstructive sleep apnea, ortho as well, and has a severe intellectual disability. So really relies on her parents to assist her with her daily needs and both medical needs as well as activities of daily living. Or we could have a 17-year-old male with JME that's stable on anti-epileptic medication, but might be still relying on his parents to do a lot. So calling in refills, and this patient is getting close to 18, calling in refills, not contacting his doctor office if anything happens to come up. So really hasn't engaged in those self-management skills that we would try to focus on early on. Next slide. So these are the 10 domains of transition readiness that we do in our clinic, but actually in the normal specialty clinics, they have access to that as well. And starting with type of health condition. So just asking your patients, why do you come see your neurologist at CHOC? What's your diagnosis? Do you know what medications you're taking? What happens if you don't take those medications? Do you happen to skip any meds? Do you miss a day here and there? Do we have to set phone alarms? I mean, you can see the discussion that we start to have. It's really important for especially females of childbearing age who wish to have maybe at some point a family in their future, to discuss reproduction and reproductive health, especially as it relates to epilepsy or maybe the medications that they're taking. Trade in school, you know, what are the plans for after high school? Or are they going off to college? Do we need to look at adult day programs for some of our other patients? So lots of rich discussion here. Changes in insurance, and then of course the process of finding new healthcare providers and looking at more of that transfer planning. Next slide. So the next couple of slides just really highlight what we do with ages. Again, this can vary a little bit. So sometimes we don't like to necessarily put the age on there, but focus more on early, mid, and late. So early, like I said, introducing what are the expectations, focusing on becoming a health history expert. So being able to describe maybe in a couple sentences, what's your diagnosis, what works, what didn't work, maybe in the past, where did you have some epilepsy medications that did not work for you, or you had major side effects. And then also focusing on healthy lifestyles as well. Nutrition, sleep, so on and so forth. Next slide. We're mid-transition. Now we're starting to move towards that independence. So that 17-year-old that I was talking about earlier and in our case study, managing these tasks, making their own appointments, refills, so on and so forth. And then planning for a future. So what is the impact of their diagnosis on career and school? Do they need support for decision making? So, are we looking for conservatorship? I know that our providers are starting to have those discussions around 17 and a half. So that way paperwork can be initiated at 18 years old. Next slide. And then late transition, 18 to 21. So again, those legal changes. What happens at 18 when our patients are legally an adult? Insurance, that's usually around age 21 for our patients that have Medi-Cal. And then also for adult care, explaining that transfer process. And that tends to happen anywhere between 18 and 21. We've met with a lot of our adult counterparts who have mentioned, look, we actually want to see your patients earlier. We don't want to wait till 21. There's a lot that we can offer if we start seeing them at 17 and 18 years old, and really start focusing on the adult aspect of care. Next slide. So I've talked a lot about our program. Again, this is our program is both program and a clinic, but I want to give Courtney an opportunity to talk a little bit more about the adolescents and young adults, or AYA's perspective, and what they'll be experiencing in our clinic.
Hello. So I did want to start with just some of the psychosocial challenges for this group. Next slide. Adolescence is a time of a lot of change. As most of us can remember, this is when independence from parents is starting to be explored. There's an intentional effort to form an identity. You're no longer seeing yourself as a singular unit with your parent. It's around this time that peers and romantic partners become more increasingly important. There's more time spent with them and in communication with them. But this is also the time when thoughts of plans for the future happen. So what's going to happen after school? Will I be going to college? Will I get a job? What is that going to look like? And while that happens for a lot of our adolescents, it's also happening for a lot of parents of young adults with intellectual disabilities. There's thoughts of what level of autonomy can be reached. Will there be programs for them after school? Will they be able to get a job? So when you think of all the things that are happening around this age, if you add in a medical diagnosis like epilepsy, it can really complicate that journey towards independence and adulthood. Next slide. So for young adults with epilepsy, there can be many concerns that their diagnosis may prevent them from reaching some of their goals. The young adults that we see in our clinic are entering adulthood with the same desires as their peers, but they're also dealing with another layer of worry. Driving has become one of those societal rites of passage. With a license comes freedom. But if you're not seizure free, then you are not able to get a license. Or if you are seizure free and you're able to get a license, there's that concern that if I have a seizure, I will lose my license. Employment also is another concern around this age. You know, what happens if I have a seizure at work? Will employers want to hire me if they know that I have epilepsy? You know, these are things that can lead to anxiety, worry about the future, and really where their place is going to be. As I mentioned before, peers and romantic partners can be pretty big at this stage. You know, so there's always the thought of like, do I disclose my diagnosis to these people? Do I tell my friends that, you know, I have epilepsy or I'm on medications? You know, and this can be a really difficult thing to navigate, you know, for a young adult, you know, just not knowing what the future is going to hold or how people are going to respond to them. But this is something that's really important and needs to be discussed when we are talking about transition and adulthood. We know that a lot's happening at this area of life for adolescents, and the psychosocial aspect is something that we address as the transition team at CHOC. Next slide. So as the slide showed before, our team is comprised of a nurse practitioner, a social worker, and a medical assistant. But I'll be touching on the social work role of our team. So during the phase 1 of the pilot programs, it was revealed that a lot of the concerns were centering around areas of social work specialty. You know, when we look at transition levels of support, some of the domains assessed were family and social support, behavioral health, and future goals. So these areas can be assessed by the social worker to identify concerns and provide linkage to services. But we want to make sure that we're having these conversations before services are transitioned out of CHOC to adult care. You know, I will want to know, what services are you connected to? What supports do you have available to you, and what are your needs? As a social worker, I'm going to have different strengths than other team members. I am the liaison between the medical team and some of those collateral agencies. But I'm also aware of like benefits, insurance, or how to access services. I'm also able to dedicate more time to care coordination than our nurse practitioner. Every patient that we see will have a medical diagnosis, medications, multiple specialties that she'll be working with, but not all of the patients will have a social work need. So that allows me more time to spend assisting those ones who have social work needs, resource needs, support needs. Next slide. So what are some of these needs? These are just a few of the common topics that come up during clinic. Changes to insurance. So depending on the type of insurance or the way your insurance was obtained, you may have changes that occur at 18, 21, 26. So that's something that we discuss. Government benefits. What happens when my child turns 18 and they have SSI? Will I lose it? Will it continue? What's the process? How does regional center play into services? Or should I apply to regional center? Conservatorship is always a big topic. So sometimes it's, you know, educating families on what conservatorship is or how to pursue it. But also, is this the right option for our young adult? You know, if they have some opinions, perhaps there is another option for them. As I mentioned, kind of the thoughts of life after high school start to happen around this time. So for some, it may mean higher education or jobs. And for others, it may be a transition program through school. It may be training in a skill or trade or in a adult day program. But all these topics will have different answers depending on the individual level of functioning. But we do explore a full range from fully independent to fully dependent individuals. Next slide. So the A to B clinic connection. This is something that, you know, we want to have early conversations. This is something we want to explore early on and not wait till, you know, they're already transitioning or leaving out the door. You know, if not prepared early on, transition to adult care can be overwhelming. As Erin mentioned earlier, the recommendation is even to start having these conversations as early as 12 years old. We want to give people a chance to ask questions, voice fears, and really mentally prepare for care outside of CHOC, which may look different. You know, some of those differences are starting with a new provider, or especially when they've been with someone for a number of years, if not their whole life, and that can be really scary. Or some parents have a difficult time no longer being included in the communication with adult providers. This is hard for some parents and also for some young adults who still heavily rely on their parents to make those appointments, call for refills, or really support them in their medical care. But when meeting with the transition team, these are some of those things that we do explain, and we do want to make suggestions for increased independence and ownership of the care for the young adult. So depending on the young adult, we can make recommendations that are big or small. Next slide. So as she had mentioned, this is the transition team is fairly new, but we've definitely been able to make some gains in the short time. We've been able to identify some gaps in transition and processes, and we're constantly reassessing those to see if there's changes that can be made or improvements that can be made. We've been also able to provide families with detailed steps of what to do next. You know, some of this won't be done all in one appointment, but you know, it's like, hey, let's just focus on this next step and then we'll move on to the next. But we haven't told that can be assuring just to know what's next. We have this quote from one of the parents that we've worked with, and it pretty much sums up what we do. You know, we're striving to partner with families, but this is an ongoing process, and transition to adult care is a work in progress, and we'll continue to, you know, work towards that goal. Next slide. So how do we address this problem? Basically, education. Education for patients, parents, providers, hospitals, and healthcare systems. You know, we want to make sure that we're having these conversations and that this is stuff that's happening early on. It can be overwhelming, as I had mentioned before, if not having these conversations until the young adult is 18 or over. Adult care transition is not a new concept, but the targeted approach is. So we want to make sure that we're really spending time on this to try to improve it. And many organizations are tackling this. Next slide. Among the epilepsy community, many support organizations are jumping in on this. The Epilepsy Foundation, Child Neurology Foundation, and the Epilepsy Support Network of Orange County all have tools and information related to transition on their websites. This is a great source of knowledge for, you know, education, webinars, and any other questions that you might have. So these are great resources to check out. Next slide. So in summary, the importance of successful transition has been well established. This is a period of high risk, and that has led to intentional efforts to improve the process and provide adequate support. Many tools have been created to support this, but communication remains really essential. Communication with providers, with the patients, with the parents, with the adult providers, really all around to make sure that everyone has their needs met and it is a successful transition. Next slide. And here is our website. So here you can find more information on transition, practice skills, what to expect of the process, and even some frequently asked questions. Thank you for your time.
I think we can open it up to questions too for a couple minutes if anybody has questions. Questions, comments, concerns. All right, well, I think that's it for us. Thank you for your attention and for attending today and having us. And we look forward to meeting some of you or connecting with you in the future.